So I think today we'll be covering an important topic on hematuria, the evaluation of hematuria, which is a reasonably common condition that we see encounter in our specialty clinics. And we have two speakers. The first is Dr. Rahul Sharma, who is a DM postgraduate student in the second year, and he'll be speaking on the evaluation of hematuria. And this will be followed by case vignettes from Professor Shriram, who's the chief of pediatric nephrology at Pondicherry. So we hope that you find the session useful. Clearly, hematuria is an important problem, as I just said. And there are countries that have national programs to monitor for hematuria. So they're all children, once in 2 to 3 years, particularly in Japan, in Taiwan, even Philippines and Korea. They would be undergoing an annual school screening when the urine would be examined and trying to pick up glomerular disorders or even non-glomerular disorders that could cause kidney disease. And the Japan Jap- our Japanese colleagues feel very strongly that after launch of the program, they have been able to diagnose kidney disease early. However, I must say that this view is not shared by all. And there is clearly, this is a controversial area whether children should undergo screening for hematuria every year or every 2 years. And most developed countries in the West, apart from Japan and Hong Kong, etc., in Asia, they would not be doing regular school screening for children, um, for trying to look for hematuria. Again, when you're trying to look for hematuria, you get microscopic hematuria that's relatively more common than gross hematuria. But one is easily able to find a cause for gross hematuria. Microscopic hematuria, the cause is often at times you're not able to figure out. However, these patients need to be evaluated carefully, and Rahul and Sriram will be going over the evaluation and the outcomes. So I won't take more time, and maybe I can now ask Rahul to begin his presentation on evaluation of a child with hematuria. Rahul.
Thank you, sir, for that introduction. Without any delay, I'll begin the presentation. Am I audible, sir?
Yes, you are audible. Please go ahead.
Okay. So this is our outline for today. So we'll see the definitions of hematuria, various definitions at various places. We'll see the pathophysiology of hematuria, the etiology, the indications for kidney biopsy, when do we work for genetic etiologies in these patients. I'll also share with you a suggested approach both for gross as well as microscopic hematuria. We'll see the outcomes of persistent microscopic hematuria, and then we'll end with some take-home messages. So when we look at definitions of microscopic hematuria, we see that there are various definitions, and those depend on places where one resides. Although that does not make much difference, because as we know, with new evidence coming up, that there's no safe lower limit of hematuria. And initially, when in 2006, when our guidelines came, we defined hematuria as 5 or more RBCs per hypoar field. But as of now, we consider 3 or more RBCs as microscopic hematuria, because it is not considered to be benign anymore. But it is always a good practice to evaluate urine and examine urine for 2 to 3 times. If there is persistence of RBCs in urine for more than 4 weeks and you have examined it more than twice or thrice, it is called as persistent hematuria. So any child, when you encounter any child with gross or microscopic gross hematuria, because that would be the most likely presentation, the first thing you need to confirm whether it is hematuria or something else, say false positive, falsely red colored urine due to many causes. So dipstick is a good screening test where there is tetramethylbenzidine, which detects the peroxidase activity of hemoglobin and myoglobin such. And there is a change of the color of dipstick to bluish green. This detects hematuria with a very good sensitivity of around 91 to 100% and a reasonable specificity. But one needs to see that there are many false positive and false negatives with urine test as well. The gold standard and the best method to detect microscopic hematuria would be a urine examination. Residents in all fields should know how to examine the urine by themselves. When you collect a urine, it should be around 10 ml ideally, and it should be examined within 1 hour of collection. If you're not able to examine within 1 hour of collection, it should be refrigerated and ideally used within 4 hours of collection. You should spin it at 400 Gs for 5 minutes. Again, various manufacturers would give various RPMs, and 400 G is what we consider the accurate measurement for defining centrifugation in these cases. You should examine these under the microscope at 400x. You can see RBCs in the microscope, even a bright field microscope, the light microscope that we use, even in unstained preparations. These RBCs will look similar to what you see in stained preparation without a stain. And you can see both RBC casts, RBCs, dysmorphic RBCs in bright field microscopy. But if you want a more sensitive test, a phase contrast microscope would be better. And you can better lineate the membrane of RBCs and in disfigured RBCs. As you can see in the image on the right, you can see acanthocytes with disfigured of the RBC membrane. When we look at pathogenesis, the glomerular basement membrane is damaged due to any cause, and RBCs passing through this are disfigured, leading to a presence of acanthocytes in urine examination. You can see a beautiful EM image on the right that that was there when RBC is passing through the damaged glomerular basement membrane. So one thing that we need to specify, one thing that we need to consider is whether the origin of the hematuria is glomerular or non-glomerular. We are worried about glomerular hematuria because they are more prone to leading to a chronic kidney disease, and that is why we predominantly see dysmorphic RBCs, the acanthocytes. So when we look at clinical features, the RBC examination alone would not point us towards glomerular hematuria, and the clinical examination would point us towards that. When we see sympharyngitic hematuria, when we see hematuria associated with rash, we see associated features in the form of hypertension. The urine color in itself can point towards glomerular causes like brown, tea, or cola colored, which is more common. One thing to note would be a proteinuria, which is of 2+ or more on dipstick, or say a higher subnephrotic or nephrotic range proteinuria. Dysmorphic RBCs, here I've mentioned 20%, but more and more we are, when we have various studies, we know that this is not an absolute number. So when we look at various studies, the dysmorphic RBCs have been studied and the cutoffs have been taken, say 20% to 22% and 25%, and in some studies up to 90% to determine the sensitivity and specificity. There's also acanthocytes, which is considered to be more specific, say a better marker for determining glomerular source. So acanthocytes of more than 5% would be, say, a good sensitive as well as specific pointer towards a glomerular hematuria. Urine examination and the history of hematuria alone is not sensitive enough to, say, diagnose. And when you look at those extrarenal features, you will have many differentials. As we see here, a child who has hematuria with edema and hypertension, you would more likely think that it is acute glomerulonephritis. Somewhere where you see there is history of purpura, you can see IgA vasculitis, and the presence of hematuria would point towards involvement of kidneys, that is nephritis. Presence of hemoptysis would lead to anti-GBM nephritis, and so on. One thing to note would be that if there is history of sensorineural hearing loss, that would point towards genetic causes. A family history would point towards genetic causes. So this is not a list that is there and exhaustive, and you may find various other clinical signs and manifestations that would point towards various differentials. The color of the urine would also point towards etiology, but then again, it should not be taken in isolation, and history is of prime importance. A proper history and examination is irreplaceable. When we look at gross hematuria, we see that even 1 ml of urine is enough to discolor 1 liter of urine. 1 ml of blood, 1 ml of blood is enough to discolor urine. And gross hematuria is, say, either a one-time thing which can be seen in acute glomerulonephritis, or a recurrent gross hematuria can be seen in something like IgA vasculitis, IgA nephropathy, which is the most common cause in children. But even with extensive evaluation, you may not be able to find the cause, as we see in these two tables. One thing that we do not know, few causes where we say genetic etiologies are coming up more and more. As we know more and more about these genes, we may be able to determine the cause in these certain patients as well. This table enlists the common as well as uncommon causes of both glomerular as well as non-glomerular hematuria. Now, kidney biopsy in evaluation of hematuria is a tool that can be used, but it should be used for specific purposes. It cannot be used for each and every child who presents with gross hematuria. So when do we consider doing a kidney biopsy would be a significant proteinuria, that is nephrotic range proteinuria, or a presence of nephrotic syndrome with hypoalbuminemia. There is recurrent or persistent microscopic hematuria which is present for more than 18 to 24 months. There's abnormal renal function, say something like acute glomerular nephritis, and the hypertension and AKI is not resolving for more than 7 days. So, or if there is an acute glomerular nephritis where there is no evidence of streptococcal infection, in these cases you would go ahead with biopsy. Previously, there were indications of kidney biopsy which have been now replaced by a prior genetic testing where we have some evidence that there may be a family history or clinical features like sensorineural hearing loss where genetics is preferred. And when we do kidney biopsy, this is an old study where isolated hematuria as well as hematuria and proteinuria were biopsied, and we can see that there was no abnormal histology in around 50% of patients. And in those 50% of patients where there was isolated hematuria, 33% had thin GBM disease, which is now a part of Alport syndrome. IgA nephropathy then becomes the common cause of isolated hematuria. Hematuria and proteinuria, if present together, would more likely be able to indicate that there is ongoing kidney damage, and that may lead to a chronic kidney disease as well. And that is what we see in pathology as well. Up to 75% of these patients would have some abnormality found on the histopathology. The advances in genetics have encompassed under the umbrella the hematuria as well. And such as in when we consider a genome-wide association study, such as in this UK biobank of around 500,000 adults with an enriched cohort where they had found that there is glomerular hematuria in more than 16,000 patients. And when they looked at their genome, they found that col4A3 and col4A4 were the most likely implicated loci in these patients. There were also two important locus, such as locus like HLA-B and PGF-beta. And they also found 3 new loci, as mentioned in the right. So genetics is coming up more and more in hematuria, persistent microscopic hematuria. A similar study from a genomics clinic in Australia of 60 odd patients where they found that there was 58 in 58% of patients there was a positive family history. They could find out that there was a genetic variant in 62% of these patients, with most common being col4A variants followed by MYH9. When we see hereditary hematuria, we always, when looking at hematuria and evaluating, we also look at families. And if there is family history of hematuria, we would be more prone, more likely considering hereditary hematuria. And when we look at the genes of hereditary hematuria, col4A5 again of the Alport syndrome is at top of the table. That in itself leads to a lifetime risk of more than 90% for development of end-stage kidney disease. We have other like hereditary angiopathy, nephropathy, aneurysms and muscle cramps, followed by MYH9 and CFHR5 nephropathy. So this is again not an exhaustive list, and we can find many and many genes as we go on. Let's look at an approach to a child with gross hematuria. The first thing that you would like to consider, is there any evidence of glomerulonephritis like edema, hypertension? And if there is, you would do a complete blood count, you would do a urea creatinine, you would look at C3, C4, and as well as ASO titer. If these investigations are suggestive of infection-related glomerulonephritis, say predominantly a post-streptococcal, we know that there is a supportive therapy for these patients. And if these indicates us, these are not indicative of post-streptococcal, say there is no low C3, These should ideally be managed by a pediatric nephrologist. If during management of these kids, if there is hyperkalemia, uremia, or hypertension, again should ideally be managed by a pediatric nephrologist. If there is no evidence of glomerulonephritis, one should ask for history of trauma. If there is history of trauma, you would investigate in the same by, say, CT, abdomen, or pelvis, and then refer to a trauma surgeon or urologist for the management. If there's no history of trauma, one should ask for symptoms of UTI. One may not be forthcoming with symptoms of UTI, or you may not. You may have to ask the parents if there is crying during micturition and such. And you would see urine culture as well as ultrasound KUB. Recurrent UTI would have its own separate algorithm. And if there is no symptoms of UTI, you would see family history of stones. Many a times you would find that there is family history of stones, and when you evaluate, there is hypercalciuria in these patients. So you would do an ultrasound KUB for evaluation of stones, and if there is an obstructive stone, that they would be better managed by a pediatric urologist. You would do a 24-hour urine collection for metabolic stone profile to determine whether there is hyperuricosuriia or hypercalciuria. If all of this is negative, you would do a complete family screen. You will look at calcium create anyways. You will look for other causes of, say, gross hematuria. If there is, you would look at hemoglobinuria. You would do HB electrophoresis, and those would be managed on the basis of whatever results you get from those investigations. If there is, say, tumor or structural abnormalities in the investigation, again would be managed by specialists in those fields. When we look at persistent microscopic hematuria, that is presence of RBCs for more than 4 weeks, if there is proteinuria with this microscopic hematuria, would straight away go with this algorithm that I would like to present. And if there is no proteinuria, you would again keep on monitoring these patients for worsening of kidney function or, say, worsening of hematuria. You would look at albumin creatinine ratio. You would look at calcium, more specifically protein creatinine ratio, calcium creatinine ratio. You would do these studies. You would do a renal ultrasound, and on the basis of those, you may find, on the basis of electrophoresis or coagulation studies, that these may be sickle cell nephropathy, hemophilia, or thalassemia that can lead to acute crisis and hematuria by causing kidney infarction. On ultrasound, you may find various causes of hematuria that are like cysts, congenital anomalies, or kidney stones. If none of these are found, you would see that there may be some extrarenal manifestation. There is associated proteinuria. If you calculate GFR, it may be low, and if you have hypertension, you would more likely be towards thinking about glomerular cause. Then you would do a serum albumin, say, for nephrotic syndrome or, say, nephrotic picture. You would do a complement. You would do ANA, dsDNA to find out lupus nephritis. You may need to do kidney biopsy, as we saw, for some indications. If all of these are normal, you would do a family screen. You would look at family history. You would do their urine examination. And if you would also inquire whether there is a family history of hearing loss. There may not be family history of hearing loss, and the child in itself would be an index case where there is history of where there is sensorineural hearing loss. If you find that there is increased calcium creatinine ratio, you would do a 24-hour urine calcium and serum calcium to look at these cases as well. On the basis of albumins, complements, and ANA, you would, say, find out, or the basis of kidney biopsy, you would find out these diagnoses. On the basis of family history, if there is any family history, you would go ahead with genetics. As I told previously, you would not biopsy. Ideally, you would first do genetics. If there is no history, you would do an yearly follow-up with urine analysis, urine protein creatinine ratio, and hypertension, which in presence of microscopic hematuria lead to a higher chances of end-stage kidney disease. If you do genetics, you would get something like Col4A changes or changes in those mentioned genes like MYH9. For a 24-hour urine calcium, you may find out that there is a higher calcium in urine, say more than 4 mg per kg per day. That is not an absolute number. We as Indians have lower calcium excretion. So anything above 3.2 would be taken as a higher calcium. So that would be a hypercalciuria. If all of these are normal, you would keep them following up with urinalysis as well as hypertension. When we look at long-term outcomes, why are we moving to lower and lower values of RBCs in urine to be defined as microscopic hematuria? These two survival curves would be better able to delineate that. The curve on the left, you can see that when the Israeli recruits for army were screened for presence of hematuria or not, those who had persistent hematuria when followed up till 35 years had a very high cumulative incidence as compared to those who did not have microscopic hematuria of end-stage kidney disease, obviously. The curve on the right shows the blue color, that is isolated microscopic hematuria, and the green colored curve is isolated microscopic hematuria with associated proteinuria. So if there is associated proteinuria, you can see the cumulative survival drop to as low as 40% by 6 to 10 years of follow-up. So you should keep monitoring these. Now let's look at some 2 to 3 etiologies rapidly, which cause persistent microscopic hematuria. First of them would be a type 4 collagen disorder, something like Alport syndrome. Type 4 collagen would have 6 chains, and they are in a heterotrimer. And when there is development of kidney and glomerular basement membrane, if there is a variant in collagen 4, the glomerular basement membrane would not be formed well, and that may lead to hematuria. Alport syndrome is now classified as X-linked Alport syndrome, autosomal Alport syndrome, or digenic Alport syndrome. Females are no longer considered as carriers, and they are a part of X-linked Alport syndrome because females by themselves would have increased chances of development of ESKD by say 6th or 7th decade, and they should be followed up as well. When you have Alport syndrome, you would start them on ACE inhibitors, which is the current mainstay of therapy for these patients. You would start them in X-linked males as well as autosomal recessive Alport syndrome at the time of diagnosis, and in the others, that is X-linked females and autosomal dominant on the onset of proteinuria. You would monitor them for kidney functions. You would do an annual hearing as well as annual eye examination to find out and to determine the hearing loss as well as lenticonus early. There are newer therapies for Alport syndrome, bardoxolone, ledimersen, and atrasentan, and these have been showing some promises in early studies, but they would need the test of time later. When we look at the other upcoming disease, that is MYH9 related disease, which were initially grouped in multiple diagnoses like Fechner, Mehiglin, Sebastian, and Mattins, now considered as one group. There is higher chances of kidney disease in these patients when the variant involves the motor head domain of the non-muscle myosin 2A protein. And there are higher chances of development of end-stage kidney disease by the development of focal segmental glomerulosclerosis, and they may need renal replacement therapy by as early as first or second decade. This image highlights the various organ systems involved in MYH9 related disease. You would see kidneys as well as liver, eyes, hearing involvement. You would see thrombocytopenia in these patients. They may lead to bleeding as well. One thing to note that these patients do not require immunosuppression, and these are not to be treated as immune-mediated immune thrombocytopenic purpura. The other etiology that I want to discuss is hypercalciuria. When you see microscopic as well as gross hematuria, you may find hypercalciuria in as high as 30% of these patients. This is a common association, and hypercalciuria leads to hematuria by injury to urothelial cells. Hypercalciuria should be followed up, and you do not start treatment at the onset. It may resolve on its own, but if it's persistent, urine alkalization by potassium citrate is needed. For familial hematuria, both hypercalciuria as well as hyperuricosiuria can be seen in up to 35% of patients, and they should be looked if there is familial history as well. These are some rare causes of hematuria, and I would like to discuss nutcracker among this, because nutcracker syndrome presents with asymptomatic hematuria, or it may present with left flank pain or orthostatic proteinuria. What happens in nutcracker syndrome is the angle between the aorta as well as the superior mesenteric artery is low, less than 30 degrees. That may lead to compression of left renal vein. That left renal vein may be compressed either episodically or continuously. That may lead to either persistent or episodic hematuria. The best way to diagnose would be USG Doppler, or better still CT angiogram, and there are some diagnostic criteria for those as well, but we'll not be discussing those. The way that you manage is predominantly conservative management, because most of these, when they grow with development, with gain in weight and height, the angle between the SMA as well as aorta increases, and their obstruction is relieved. There may be indication of surgery in very few, and these would be done on case-to-case basis. I would like you to take home these messages that good bedside urine analysis is the key, and one should know how to examine urine and what else to do and how to do it. And you should, the more you do, the more you get better at it. Glomerular hematuria, as I told, carries a significant long-term risk, and it needs detailed evaluation. You should always screen for extrarenal features. And renal biopsy is only done if it significantly alters the management. Persistent microscopic hematuria is not always benign, and it should be evaluated, and you should look and find out the causes. And you should always remember the rare causes of hematuria as well. Thank you.
Thank you, Rahul, for that comprehensive presentation. For want of time, I think we will move forward. And I would like to invite Dr. Sriram for his presentation. Dr. Bagga, any comments from your side before we proceed?
No, I think we just carry on. Yep. Thank you. Sriram.
Yeah. Thank you, sir. Good evening. Am I audible?
Yes, you are.
Okay. Good evening. Evaluation of hematuria through case vignettes. So, previous speaker, Dr. Rahul, has already discussed the approach to a child with hematuria in terms of glomerular diseases and non-glomerular diseases. And I will not like to go into this further. So, the glomerular versus the non-glomerular hematuria is also differentiated based on a proper history taking, examination, and the presence of dysmorphic red blood cell casts, and the degree of proteinuria. So my first case is a 5-year-old boy who presented with cola-colored urine, periorbital edema, and oliguria for 3 days. He had multiple pyodermas 3 weeks ago, and his blood pressure is found to be more than the 95th centile. The urine microscopy shows red blood cell casts with 30 red blood cells per hypa field, which are 50% dysmorphic. There is a subnephrotic range of proteinuria. The creatinine is 0.71, which, if carefully calculated, the estimated GFR would come to 68 ml per minute per 1.73 meters square by the modified Schwartz formula, indicating that there is mild acute kidney injury. The C3 is low, and the ASO is found to be normal. The serum albumin is normal, 3.5 grams per deciliter. Now, should we do a kidney biopsy in this case or not? So kidney biopsy is not required. These are the pictures showing the dysmorphic red blood cells and the red blood cell casts. So the features of this case are the presence of a glomerular hematuria as indicated by the dysmorphic red blood cells, red blood cell casts, hypocomplementemia. This was preceded by pyoderma 3 weeks prior to hematuria. There is a hypertension with edema, and there is a mild acute kidney injury. So all this suggests a post-streptococcal glomerulonephritis. And this cartoon summarizes the typical clinical course of post-streptococcal glomerulonephritis. So you would see that the hematuria and hypertension improve over a period of about 2 weeks or so. But the C3 continues to improve. And one of the most important signs of PSGN is that the C3 comes back to normal in about 6 weeks period. So another important thing about this case is that the ASO was found to be negative. So the anti-streptolysin O can be negative in PSGN, as the anti-streptolysin O is bound to skin lipids and it may not be released in the circulation. So anti-DNase B is more specific. This child was managed with salt and fluid restriction. IV furosemide was required for control of hypertension and edema. And at an 8-week follow-up, the C3 normalized, indicating that this was a post-streptococcal glomerulonephritis. The eGFR at an 8-week follow-up is 104, which has markedly improved and come back to normal. The blood pressure is normal. There is no albuminuria. Some microscopic hematuria is persisting, which is known in PSGN. It may last for some years. So what are the indications for biopsy in acute nephritic syndrome? In this case, it was not required, but the ordinary indications are when you suspect a rapidly progressive glomerulonephritis, when there is absence of hypocomplementemia at admission, when there is persistence of hypocomplementemia for more than 8 weeks, when there are mixed nephritic features, when there is a gross hematuria for more than 4 weeks, when there are extrarenal features like malar rash, palpable purpura, hepatosplenomegaly, rash or arthritis, or absence of any evidence of an infection that triggered the glomerulonephritis. So after this case of PSGN, Let us go to case 2. This is a 7-year-old boy who presented with fever, cough, and throat pain for 3 days. There was a cola urine with periorbital edema for 2 days with oliguria, and he was actually referred as a post-streptococcal glomerulonephritis. There was no family history of kidney disease. The blood pressure is high, and he had mild periorbital and pedal edema. There were no pyodermas, rash, or arthritis. The laboratory investigations confirmed a glomerular variety of hematuria with 80% dysmorphic red blood cells and red blood cell casts. The urinary protein creatinine ratio is 1.2, indicating a subnephrotic proteinuria. The serum creatinine here is normal. The serum albumin is normal as well. The anti-DNase B is normal. Serum C3 is found to be normal in this case. It's 95. So what to do further? Is biopsy indicated? So in this case, the indications of biopsy would be normocomplementemia in the setting of an acute nephritic syndrome, as well as pharyngitic hematuria. So a kidney biopsy was done, and the kidney biopsy suggests diffuse mesangial expansion and proliferation in the glomerulus, and it shows IgA in the glomerular capillaries and mesangium, confirming a diagnosis of IgA nephropathy. So currently, we use the Oxford classification of IgA nephropathy, which uses a combination of mesangial hypercellularity, endocapillary hypercellularity, segmental sclerosis, tubular atrophy or interstitial fibrosis, and the presence of cellular or fibrocellular presence to arrive at a scoring system. So according to this scoring system, this child had M1, E1, S0, T0, and C0. This child was started on enalapril, which is given in IgA nephropathy. Prednisolone was added since the M and E scores were high, and the subsequent urinary protein creatinine ratio was found to be in the nephrotic range. The child received calcium supplements, and on follow-up at 6 months, the eGFR is found to be 110, and urinary protein creatinine ratio has also normalized. The blood pressure has normalized. On follow-up, this child had a relapse after 2 years with recurrence of hematuria and proteinuria, and he was treated with steroids and enalapril. So after this case of IgA nephropathy, let us see the third case, a 10-year-old boy who presented with low-grade fever, mild cough, coryza for 3 days. He consulted a private practitioner and took some drugs. Thereafter, he developed a dark-colored urine and pallor. On examination, he had severe pallor. The spleen was mildly palpable. There was a stage 1 hypertension. The chest, CVS, and CNS examination were found to be normal. The hemoglobin was very low, 3.7. The platelet counts and TLC were normal. Peripheral smear showed no schistocytes. There was a reticulocytosis, and there was a LDH being very high, 750. Repeated smears for malaria were negative. The serum creatinine was high, 1.4, indicating acute kidney injury. The urine microscopy showed no red blood cells, no proteinuria. So is this actually hematuria? No. What are the possibilities of dark red colored urine with urine red blood cells being absent? In this case, we also observed that the urine for hemoglobin was positive by dipstick. So actually, this is a case of intravascular hemolysis. On further workup, this was diagnosed as G6PD deficiency. So the learning points in this case are, this is actually a case of hemoglobinuria, not hematuria. One should not suspect say that it's a hematuria in the absence of red blood cells. Causes of hemoglobinuria, such as drugs, malaria, and snakebite, should be considered. And always rule out mimics of hematuria, including hemoglobinuria, drugs, and food items such as beetroot. Our fourth case is a 12-year-old girl who presented with a red-colored urine, edema, and oliguria for 2 weeks. She had a reddish malar rash and rash over the abdomen and limbs as well. There were no extrarenal features like chorea, convulsions, pleural effusions, arthritis. On examination, she had a rash over the malar region and limbs. She was stage 2 hypertension with periorbital and pedal edema. She had glomerular hematuria with subnephrotic range of proteinuria. The complete blood counts were normal. The serum creatinine was 0.54, which was normal. The serum albumin was very low, 2.7. And the urinary protein creatinine ratio was in the nephrotic range, more than 2. So is kidney biopsy indicated in this case? So you have a child with acute nephritis syndrome who has presented with rash, and she has a mixed nephritic picture as well. So the indication for biopsy in this case is extrarenal features with mixed in the form of rash and mixed nephritic features. So when you have a rash with hematuria, the differential diagnosis would include SLE, IgA vasculitis, which is formerly called HSP, Henoch-Conine purpura, then ANCA vasculitis, such as granulomatosis polyangiitis, and microscopic polyangiitis. So the further investigations in this case revealed an ANA and dsDNA positive, and C3 and C4 both to be low. So what should be done next? So you do a kidney biopsy, and this kidney biopsy is suggestive of a class 4 lupus nephritis. There were 10 glomeruli, no crescents, but the activity index was found to be 4 out of a total score of 24, and the chronicity index was found to be 0 out of 12. There are a lot of wire loop lesions, karyorectic debris, and you can see in the 2D section, the Jones-Silver stain shows subendothelial, intramembranous, PAS-positive immune complex deposits. The immunofluorescence shows full house positivity in the form of IgG, IgM, IgA, C1q, and C3. So this is actually a case of class 4 lupus nephritis. She was pulsed with methylprednisolone pulses, followed by monthly cyclophosphamide pulses. Total of 6 pulses were given. Prednisolone and hydroxychloroquine were added, and enalapril was also added later due to persistent proteinuria. MMF maintenance has been going on for the last 1 year, and she at follow-up has no hematuria or proteinuria. The serum creatinine is also normal. Our 5th case is a 9-year-old boy who presented with red-colored urine for a week without any fever, burning micturition, rash, or edema. There was no history of drug intake. A family history was significant. We were told that the mother has CKD stage 3A and the cause was unidentified. She was thought of as a CKD-U by our adult counterparts, and the blood pressure was found to be normal without any edema or pallor. The urinalysis showed plenty of RBCs with 2+ proteinuria. The serum creatinine was normal. The C3 was normal. The serum albumin was found to be 3.8, which was normal. The previous records 2 years ago indicated 15 red blood cells per hypoph field, with the urine albumin being nil. Child was born to non-consanguineous parents. So in this case, you have recurrent hematuria. So the causes could be IgA nephropathy, Alport syndrome, hypercalciuria, or a thin glomerular basement membrane nephropathy. The further investigation showed the pure tone audiometry suggestive of bilateral sensorineural hearing loss, and the eye examination showed no lenticonus cataract or macular lesions. The genetic testing by the next generation sequencing revealed a hemizygous pathogenic COL4A5 mutation. This is inherited in an X-linked dominant manner, confirming X-linked Alport syndrome. Counseling was done for Alport syndrome. Enalapril was started, and the mother's urinalysis was done, which showed red blood cells in our urine. She was also found to have sensorineural hearing loss on pure tone audiometry, and the adult nephrologists were informed that this is actually a case of Alport syndrome, and the diagnosis was revised. Now we have a 7-year-old girl who presented with recurrent red-colored urine, which was not painful. She had no edema, pallor, rash, oliguria, or fever, no seizures or tetany, no family history of kidney disease. The serum creatinine was normal. The serum calcium, phosphorus, bicarbonate, magnesium, uric acid were all found to be normal. There was no hypocomplementemia. The urinalysis revealed 42 red blood cells per hypoph field with subnephrotic range proteinuria. So basically, you have a non-glomerular hematuria in this case, with a lot of serum biochemistry being normal. There's no alkalosis, the serum creatinine is normal, and the ultrasound KUB shows normal-sized kidneys with normal echogenicity, no hydronephrosis, no ureteral dilatation, no stones, bladder normal. The pure tone audiometry and eye examination were found to be normal. So what do you do next? So in this case, we did 24-hour urine investigations, which showed urinary calcium to be more than 4 mg per kg per hour, indicating hypercalciuria. But the 24-hour urinary oxalate, uric acid, and protein levels were normal. Why the 24-hour urinary creatinine is done in this case is to quantify a good urine output. and this was found to be 15 milligrams per kg per hour, indicating that the collection was good. So this is actually a case of hypercalciuria. Whenever you have hypercalciuria, we should rule out secondary etiologies. Secondary etiologies include hypercalcemia, renal tubular acidosis, Bartter syndrome, Dent disease, primary hyperoxaluria, etc. So in this case, we could not establish any such cause. So this was thought of as an idiopathic hypercalciuria. The next generation sequencing showed heterozygosity of the SLC34A3 gene, which is now increasingly described in idiopathic hypercalciuria. It's inherited in an autosomal dominant manner. This child was started with thiazides. Potassium citrate was added later, and she is on follow-up. Our last case is a 5-year-old boy who presented with bilateral flank pain, painful red-colored urine for a week, no oliguria, edema, fever. Urine output was normal. The anthropometry was normal. The bony skeleton was normal. The serum creatinine was normal with an eGFR of 98. And the serum biochemistries such as sodium, potassium, bicarbonate, chloride, magnesium, calcium, phosphorus, hemoglobin, all were normal, with the urine showing non-dysmorphic red blood cells, 140, without any proteinuria. The urine albumin was nil by dipstick. There was no glycosuria, no white blood cells in the urine, no casts. What should be the next step? So we have a non-glomerular hematuria in this case, with a lot of serum biochemistries being normal, such as the bicarbonate, calcium, magnesium. These are all found to be normal. So we do urine investigations. So in this case, you have 24-hour urinary calcium, more than 4 milligram per kg per hour. The 24-hour urinary oxalate is 125 milligram per 1.73 meter square in 24 hours. If this is more than 40 milligram per 1.73 meter square in 24 hours, it's considered as hyperoxaluria. The 24-hour serum, 24-hour urinary protein and urinary creatinine was normal. The ultrasound KUB showed bilateral nephrocalcinosis with small stones in the pelvic calycial system, but there was no hydronephrosis. You can see in the X-ray that there is a bilateral nephrocalcinosis. So what could be the causes of medullary nephrocalcinosis? We consider primary hyperoxaluria. Then other causes of medullary nephrocalcinosis in this case were ruled out. And these include distal RTA, Bartter syndrome, Dent disease, hypercalcemia, and familial hypomagnesemia with nephrocalcinosis. So further investigations showed a double homozygosity in the AGXT gene. And this confirmed a primary hyperoxaluria type 1. The child was started on potassium citrate and pyridoxine and advised increased fluids. At 4 years, she has progressed to CKD stage 3B. So my key messages are, from all these cases that we have seen so far, we should always distinguish hematuria from hemoglobinuria and other spurious causes. Classify the hematuria as glomerular or non-glomerular to ascertain the etiology. Post-streptococcal glomerulonephritis is an important cause of hematuria, but then every case of hematuria is not infection-related glomerulonephritis or post-streptococcal glomerulonephritis. Mimickers of PSGN, such as IgA nephropathy and lupus nephritis, should be carefully ruled out. History of rash, palpable purpura, or any extra renal involvement or NSAID intake should be sought in all these cases to rule out etiologies such as lupus, ANCA vasculitis, etc. Family history of kidney disease or hematuria can help you narrow down the differential diagnosis. For example, I showed a case of Alport syndrome. Imaging studies and genetic studies can help in the evaluation of hematuria. And when you have recurrent hematuria, always consider IgA nephropathy, Alport syndrome, hypercalciuria, stones, and thin basement membrane nephropathy. Thank you.
Thank you, Rahul. It had been a really nice and comprehensive presentation of a lot of cases, and you have stick to the time. I would like to ask Dr. Bagga for his comments and further proceedings.
Well, thank you very much, Susan. And I think both talks were very crisp and to the point, and I hope the messages went clearly to our residents and to our participants. Chiefly, I think the step one partly is to differentiate a glomerular from a non-glomerular hematuria. because your plan does change based on that. I agree that it may not always be possible, but I think one should still try one's best to figure out whether what's the site of bleeding, and then thereafter, one can plan evaluation based on whatever you are. So, if you're thinking about extraglomerular cause, ultrasound and so on, doing urine biochemistry is clearly very important. And if you're thinking about glomerular causes, as Dr. Sriram just said, uh, do think about post-infectious or what we call infection-related GN now, and then other secondary causes. And do remember, that at times in familial hematuria, you may have conditions that are genetic. So clearly, that's something that's helped us uh, plan our management in children who have asymptomatic microscopic hematuria, where you can't find a cause otherwise. So I'll stop here, and we are happy to address questions meanwhile.
So,
So Sriram and Rahul can probably
yeah,
answer the
so
question.
please, participant, please send your question in Q&A section. Meanwhile, we'll start with post-test quiz. After that, we'll discuss the doubts if you have. Sneha, are you there?
Yes, ma'am.
Hello.
Yes, sir.
Can you please share the post-test quiz link?
Yes, yes, sir.
So Sriram, while the people are trying to address questions, how
Yes.
commonly would you do a CT scan? How often would a CT scan be required for evaluation of hematuria? Do you think it's an important investigation, or you would be able to get your diagnoses with a good ultrasound in most cases?
With a good ultrasound, we should be able to make a good diagnosis. CT would give a lot of radiation to children and is not ordinarily recommended as per the current recommendations. Even for a stone evaluation, a good ultrasound and sometimes maybe an X-ray if you want to find out whether it's a radio opaque or a radiolucent stone, that may be enough. But even an X-ray is not always recommended.
Yeah. So I think the message is very clear. Yeah.
Just Sneha, we are not asking for Google form link, please. You need to share, the post-test quiz which you are supposed to conduct on Zoom meeting or Kahoot.
Sir, should I start the poll, sir?
Yeah, that's what I am asking for.
Yes, sir. Sir, you are not properly audible. Yes, I'm starting.
Jitendra, hope you've closed the pre-test.
Yeah. Close, ma'am, already. Close it.
Okay, sir. Okay, ma'am. I'm starting the polls.
So there are. So Jitendra, can you hear me?
Yes, sir.
So there are some questions, Dr. Rahul.
Sir, we'll discuss the question immediately after post-test.
Okay, I'm sorry.
This thing.
Sorry.
We would
Yeah.
have almost 10 to 15 minutes to discuss.
Okay.
those.
Okay. So all right. Okay.
Okay, should I start?
Yes.
Yes. Every question is 30 seconds. Okay. Ten,
So
20, 30. Moving to the next questions. Twenty, 'Moving to the next questions. 10, 20, 'Moving to the next question. Ten seconds. 20 seconds. 30. Moving to the next question. Ten seconds. 20 seconds. 30 seconds. Moving to the next question. Fifteen seconds. 10 seconds more. Moving to the next question. Ten seconds. 20 seconds. 30 seconds up. Moving to the next question. Ten seconds left. Moving to the next question. Fifteen seconds more. Moving to the next question. Fifteen seconds more. End. So questions are completed, sir. Over to you.
Thank you. So there are questions.
So your voice is breaking, sir.
Hello.
Hello, sir, your voice is breaking.
Am I audible now?
Yes, Jitendra, you are.
So there are questions in chat box. One of the question is adenovirus causes bright red urine or cola colored urine.
I'll like to answer, sir. So adenovirus can cause hematuria in two senses, in the form that adenovirus can cause adenoviral cystitis that may lead to, say, red urine with clots, or it may also cause glomerular hematuria in cases where there may be cola colored urine or incidentally picked up microscopic hematuria. So all types of hematuria have been documented with adenovirus, but the most commonly that we see would be adenoviral cystitis that leads to bright red urine, and there is passage of clots in a few of those as well.
Okay, thank you. So one of the participants is asking that after how many days of UTI would you reassess for hematuria? I'm not really sure what is trying to ask. So
Yeah, I would still answer. So in UTI, when you have hematuria, when you do urine routine examination, you may find hematuria microscopic, or sometimes, as in cystitis and all, gross hematuria. We do not routinely assess for persistence of hematuria in cases of UTI, but incidentally detected hematuria that may present with fever without other signs of, say, UTI may need to be repeated. We again repeat twice or thrice, maybe at least 1 month apart, or say and have 2 to 3 repeat evaluations to confirm that there is persistence of hematuria, which would not be explained by UTI in itself.
So next question is that, is there any other way except microscopy that we can differentiate between hematuria and hemoglobinuria?
One of the things that is not absolute, but when we centrifuge urine, if the supernatant is clear, that would more likely point towards hematuria, and if it say there's a pinkish tinge, that may indicate hemoglobinuria, but that is not confirmatory. And you would have to go for microscopy one, or in other forms you can look for urine for hemoglobin that specifically tests for urine free hemoglobin, and if that is present, that may point towards hemoglobinuria rather than hematuria.
Okay, so I don't see any other question. If we still have, around 10 minutes. So next, one more question, that how long should we follow up a case of post streptococcus GN with microscopic hematuria even at 2 years of follow-up?
So we do not expect persistence of microscopic hematuria more than 18 to 24 months in cases of acute glomerulonephritis like those of infection-related GN. So that would become an indication for biopsy, as I had mentioned, and then you would like to see what exactly is going on, then that is causing the persistence of microscopic hematuria.
Any role of MCUG in evaluation of hematuria?
In hematuria in itself, I don't think so there is any role. What you would look for in MCUJ is predominantly reflex the bladder wall, and as such, which is seen predominantly in cases of VUR or CKD, unknown CKD you would like to evaluate, but not specifically in isolated hematuria, no.
One of the resident is asking that they don't have centrifuge. Can we take help of gravity, like keeping sample stable for 24 to 48 hours for examination?
So one should know that urine has bacteria in it that may lead to changes in pH, that may lead to changes in other things. There may be growth of bacteria as well. And RBC membrane is not stable for such long. So that is why you may not be able to detect RBCs in those cases. So there's no, that is why we specify that it should be examined within 1 hour and ideally within 4 hours, because if refrigerated, because refrigeration takes care of that activity that is going on, and that is halted for at least for 4 hours, what is seen.
Okay. So one of the resident is asking that, that when we are asking for a ultrasound imaging in the patient with hematuria, what should we be, requesting the radiologist? What are specific things?
When you want to see when you want to evaluate by radiology by say ultrasound, the most commonly that we see is any evidence of congenital anomalies of kidney or urinary tract that may lead to higher chances of UTI and higher chances of hematuria. The other would be cysts in itself that may lead to increased chances of hematuria. Hypercalciuria and nephrolithiasis are underappreciated as a cause of hematuria without pain. They can present without pain as well. So as said, ultrasound is sensitive enough to detect these cases. So all these possibilities should be written. Again, those possibilities you cannot write it blindly. The clinical picture would point towards that as well. So I have one comment that mentions that dipstick can differentiate between hemoglobinuria and hematuria, if that is what is written here. Dipstick will detect hemoglobinuria as well, and if you want to differentiate, that is a very crude method that you may find some dots in cases of hematuria and even color in cases of hemoglobinuria, but that is not definitely a good test to differentiate between hematuria and hemoglobinuria.
The
Both
dipstick
would
should
have
not be
changing
used to
color.
differentiate between hematuria
Yes, sir.
and hemoglobinuria,
Exactly.
because both may pick up heme.
Yes, sir.
One of the participant asking that is renal vein thrombosis causes hematuria, which obviously is one of the causes of hematuria is renal vein thrombosis. The question related to post-streptococcal glomerulonephritis and neurogenic bladder will be discussed in further seminars, so I won't be taking. So does it, IgA nephropathy question. So one of the question that, was the final consensus of defining hematuria, whether it's more than 5 RBCs or more than 3 RBCs per high power field.
As I told that there's no safe lower limit, but if there is persistence of hematuria, even 3 RBCs is defined as hematuria. So as of now, even at various centers, including our at AIMS, we define hematuria as 3 or more RBCs per high power field.
The next question is, does every child with nephrotic, which is probably they are meaning that, nephritic syndrome with nephrotic range of proteinuria require biopsy?
Yeah, mixed nephritic features would be an indication for kidney biopsy, because you could be having some non-post-streptococcal etiology most likely. It is very uncommon in PSGN to have full-fledged nephrotic syndrome. That's reported very rarely, so it would become an indication.
Okay. So before we close, the session, would like to have comments from our moderators for the day. Baga sir, Susan ma'am.
No, I think very well done. Thank you. I think there are no comments. So I think, and the questions were responded to well, by both Rahul as well as Sriram. So I think thank you for a clear and a very crisp presentation as well as the cases. There are no comments from my side. Thank you.
Yeah, very well conducted and well received session, as evidenced by the lot of questions and discussions that was following. And congratulations to Rahul and Sriram for that real good class that you have taken. Thank you.
Rahul, there are few more questions. Can you answer that in chat, the Q&A section?
I will do that, sir.
So before we, coming close to the next section, the next session would be, I'll share the flyer for next session.
Yes, sir.
And next webinar on this series would be on radiological and nuclear scintigraphic imaging for kidney disorders, and that would be on next Friday. And for that would be having as a moderator Professor Susan Uthup and Professor Rakesh Kumar, who is Professor of Nuclear Medicine, Nuclear Imaging at AIIMS New Delhi, and the speakers would be Dr. Girish Bhatt, and case discussion would be by Dr. Kanika Kapoor from Sufdurjung Hospital. There are, couple of announcements that for, participants, the link for joining each and every session is same. So please don't confuse it. If you're not getting by mistake any, mails, you can join with the same link which have been circulated to you previously. So we don't have, the separate link for each and every session, is same link by which you can join. Aditi ma'am, any other comments which you want to make?
Yes, we will. We have sent to you emails about the prior videos where they are posted. Someone has asked kindly share the links for previous sessions. We didn't get previous session video links. In case you're having a problem, please write to either of us individually. We will ensure you'll get it. Overall, we have made sure that all delegates get the links to the previous sessions. Some people have requested for a WhatsApp group. We overall were not very keen to do that, but if it is seemingly such a problem, we'll create one and send an invite link. If people have specific queries, you could ask there, but avoid from repeating messages. These were the major things. I mean, I think there was some issue today around joining, and I think because of which we have some people on live stream and some people on the Zoom window. I hope we won't have such problems again in the future. That's all. Thank you.
So we are done for the day, right?
Thank you everyone for sharing your valuable insight. We are
Thank you.
more than grateful to you, everyone's presence here. Thank you so much. We will meet our next webinar soon. Thanks to all. Thank you.
Oh.